Okay, so today I'm going to discuss about microcirculation and heart failure pathophysiology, right?
Yes.
So this is basically this kind of there's a two type of the pressure inside. This is a arterial end of the capillary, right? This one is arterial end of the capillary, and this is venous end of the capillary, right?
Yes.
So here is the blood entered, and so in capillary, inside the capillary, one is hydrostatic pressure. Hydrostatic pressure, right?
Yes.
Okay. So another pressure is
Kotik brush.
osmotic pressure, right? Osmotic pressure. Osmotic or oncotic pressure. So this hydrostatic pressure is mainly determined by water or fluid. Water or fluid, right? And
Yes.
this oncotic pressure is mainly determined by
Protein.
plasma protein. Which protein mainly?
Albumin.
Albumin. Albumin is the most abundant plasma protein, right? So the hydrostatic pressure, this hydrostatic pressure pulls fluid. This hydrostatic pressure pulls fluid out from the capillary in the interstitial space, right? And this oncotic or osmotic pressure hold the fluid within the capillaries. So there is a balance in between the capillary hydrostatic pressure and capillary oncotic pressure. Okay, so hydrostatic pressure pushes fluid out, right? This pushes fluid out, this hydrostatic pressure out of the capillaries. And this oncotic pressure pulls or hold the fluid inside the capillary, right? So there are two another pressure that is not clinically so important. So one is interstitial hydrostatic pressure, right? Interstitial hydrostatic pressure. And another one is interstitial oncotic pressure, right? Okay. So what does hydro interstitial fluid all this interstitial hydrostatic pressure pulls fluid toward the capillary, and capillary hydrostatic pressure pushes fluid out of the capillary, right? So the interstitial pressure and capillary pressure work opposite, right? Niman, does it make sense?
Yes. Yes.
Okay. So why these pressure are important? Because of there is a reason, pathophysiology behind these pressures. Okay. Let's suppose if you're talking about that capillary hydrostatic pressure. So this hydrostatic pressure. So can you tell me the any condition in which this hydrostatic pressure is increased?
Heart failure.
Heart failure.
Heart failure. That is a very high yield. Heart failure increase this hydrostatic pressure. If this hydrostatic pressure is increased, what will happen? Fluids move out from the capillaries, and there is an increased fluid in the
Interstitium.
and this is called edema, right?
Yes.
So if it is in peripheral tissue, then it is known as peripheral edema, right? And if in it is pulmonary vasculature, then it is known as pulmonary edema, right?
Yes.
Okay. It makes some sense. It makes some sense. Okay. So due to the increased hydrostatic pressure. So what terminology? It is exudate or transudate fluid?
Is transudate.
It's transudate.
Yes, transudate.
Okay. If it is due to the decrease on cortic pressure, then it is
Exudate.
No, it is
transudate.
also transudate also.
Okay.
Yes.
This concept is again high yield and it is very confusing. Transudate was exudate. So transudate fluid, any fluid that is due to increase hydrostatic pressure or decrease on cortic pressure. In which condition on cortic pressure is decreased?
Nephrotic syndrome.
Nephrotic malnutrition.
Nutrition, malnutrition. One is
Liver
nephrotic
disease.
liver diseases, nephrotic syndrome, liver pathologies, and malnutrition, right? So it will lead to transudate, and in this way it lead to edema, right? What about the exudate?
Inflammatory malignancy.
The culprit is increase capillary permeability. Increase capillary permeability,
Permeable.
right?
Yes.
Increase capillary permeability. Any condition that lead to the increased capillary permeability, it lead to exudate. So toxins, infections, inflammatory state, and burn.
Malignancy.
Yes. So what they do, they increase the capillary permeability, right? In this way, it will lead to exudate fluid and edema, right? Is there any question regarding these concepts?
Yes. It's a little bit confusing. So I don't know if you can just do a recap of it.
Okay, I will share the recording. If you still have any question, you can ask me on WhatsApp.
Okay.
Okay, so this concept is majority of the participants got this concept. Okay, so this is again the repetition of the same concept, right? This is a repetition of the same concept. So exudate, this is normal capillaries, right? So this is a protein, and this protein give rise to oncotic pressure, right? And fluid give rise to
Hydrostatic pressure.
hydrostatic pressure. And these capillary permeability, there is no space in between these capillaries, right? No space. So in exudate fluid, what will happen?
You said what? And this capillary has no what?
There is decreased space in between the endothelial cells, right?
Okay. Oh, yes. Okay.
These are endothelial cells. Here is the capillary permeability is increased. It means the space in the endothelial cell will increase. So these proteins will leak out, right?
Yes.
Okay.
Any condition that toxins, burns, right?
Okay.
They will lead to the increased capillary permeability, increased vascular permeability, or capillary permeability is the same thing. And in this way, they lead to exudate fluid and edema formation because there is an excess fluid outside the cell. So this is a transudate, right? To transudate, what will happen? There will be the increased hydrostatic pressure or will decrease the oncotic pressure. So increased hydrostatic pressure pushes the fluid out and decreased collide oncotic pressure because oncotic pressure hold the fluid inside the capillaries. If it is lost, fluid will lost from inside the cell and it will move out from the cell, right?
Yeah.
Yes.
Okay. I have a question. So are you saying that for exudate, basically when there's a damage to the membrane and
No,
the fluid that
no. I'm saying the permeability will increase. The space between the endothelial cell will increase.
Okay, but you talked about like burn. If there's a burn, would there not be a damage? That's what I'm trying to. That was what I was trying to verify before, and now
Okay,
you brought it up again.
burns also increase the capillary permeability, increase vascular permeability, right?
Okay.
Okay. So this is a pathophysiology of heart failure, right? So can anybody tell me what is a heart failure?
Basically, the heart failure would mean that the non-possibility of the heart to pump out blood adequately.
Okay. So it's basically pump failure, right?
Yes.
So pump failure means decrease. If it is unable to pump the fluid, blood, then what will happen?
There will be a backup.
Decrease perfusion,
Yes.
right? Decrease perfusion of tissue. Okay. So this is a beginning. Some injury lead to the decreased cardiac output, right? So what it will do? Heart will try to compensate by activating renin-angiotensin-aldosterone system and sympathetic system, increase sympathetic activity, right?
Yes.
Okay. So this renin-angiotensin-aldosterone system do many effects, but I am only discuss the significant event that lead to the heart failure. Increase angiotensin 2, right? And this angiotensin 2 will lead to increased aldosterone and increased ADH. Aldosterone is released from which area?
Suprarenal
From
cortex.
the posterior pituitary.
Suprarenal cortex.
Adrenal gland, right?
Yes.
Adrenal gland, which portion?
The glomerulosa.
Reticulata, zona reticulata.
No. GFR, glomerulosa.
Okay. So ADH released from which area? Which area of the body?
It is in the posterior pituitary.
Posterior pituitary, right?
Yes.
So aldosterone, what is the function of the aldosterone?
Aldosterone acts on the collecting ducts too. Basically, it works on the resorption of sodium to the between and to the pass out potassium and hydronium ions.
Okay, so it work on the tubules of the kidney nephrons.
Collect. Yes.
Yeah, right.
Yes,
So
collecting the
what it will do? It will increase sodium retention,
sodium resorption retention. Yes.
and this increased sodium retention increase water absorption, right?
Yes.
Okay. So what ADH do?
Reabsorb the
It
water.
is water resorption.
ADH
prevent
work
water
on
loss.
two receptors, V1,
And V2.
many receptor, but the most important V1 and V2, right? So
Yes.
V2 lead to the increased aquaporin, water channel. This aquaporin channel increase
Water
water
reabsorption.
Water.
on nephron, increase water reabsorption at nephron, right?
Yes.
Yes.
So when it is worked through V1 receptor, it will lead to the vasoconstriction,
Concentration.
right?
Yes. Yes.
So another name of ADH is vaso,
The present.
Vasopressin.
Yes.
so in this way, increase aldosterone and ADH leads to increased circulating volume, right?
Yes.
Increased circulating volume lead to increased venous return to heart. So increased preload, right?
Right.
So increased preload lead to the increased stroke volume. Okay. So this angiotensin through release of ADH. ADH work on V1 receptor and it will lead to the vasoconstriction, and this increase to venous tone and increase arterial tone. And in this way, it will lead to the increased blood pressure if it is a decrease initial in state. So blood pressure is a maintained, cardiac output is maintained, and stroke volume is increased. Initially, cardiac output it is decreased, right? So initially, it gives some beneficial effect, right?
Yes.
Okay, decreased cardiac output do many things. So it increased sympathetic activity. So the catecholamines are increased. These catecholamines act on heart, SA node. SA node has through which receptors? Which receptors?
Beta 1.
Beta 1 receptors, right? And
Yes.
increase contractility, right?
Yes.
So and the catecholamines also increase the vasoconstriction. Okay, these tests that heart is continually facing: increased preload, increased stroke volume. So if you increase the preload, it will increase the stress on heart. Heart is already failing, right? And you are continuously giving increaser and increaser blood to pump for the heart. So if this condition is left untreated, it will lead many deleterious remodeling changes on the heart, right? So the treatment of the heart failure is basically to prevent this pathophysiology, to target these areas, right? Okay. Now there is a pharmacology integration with pathology. Okay. Can anybody tell me the drug that decrease the mortality in the heart failure?
ACE inhibitor.
Inhibitors.
beta blocker, ARBs, ACE inhibitors.
Decrease mortality. Okay. ACE inhibitor,
Yes.
ARB,
The-
beta blocker,
الانجيوتنسين receptor blocker, الانجيوتنسين converting enzyme inhibitors.
sorry.
He has it already.
Okay, beta blocker.
S inhibitors.
It's there already. He already has it.
Okay. Okay. What about aldosterone? Okay. So if you're talking about ACE or ARB, you are inhibiting this pathway, right?
Aldosterone receptor blockers.
Yes. Spironolactone. You are inhibiting this pathway, right?
And neprilysin inhibitors.
This is a very, very high yield neprilysin inhibitor. This is neural. Can anybody tell me the drug name of neprilysin inhibitor? Sorry? Cubitril. Right. Absolutely right. So, cubitril is newer drug that also decrease mortality in the heart. So why I am discussing? Because you have to identify the drug that decrease the mortality in the heart, right? Heart failure. So if you beta blocker, so the beta blocker targets the sympathetic system, right? Okay. What about the loop diuretic? Does it has any role in decrease mortality?
No.
No.
Okay, so it is only for the symptomatic relief. Okay, this decrease mortality in which heart failure? Systolic or diastolic?
That would be that.
Systolic heart failure.
Yeah.
What about the treatment? What about the treatment of diastolic heart failure? Okay, we will discuss systolic and diastolic heart failure in a few minutes. Okay, so this is basically the systolic heart failure, decrease mortality in systolic heart failure, right? Okay. It makes some sense.
Yes.
Okay. to discuss the drugs. Okay, can anybody tell me about the differences between right heart failure, left heart failure? Okay, so let's suppose this is our
Well,
heart, right? So this is
yes.
right atrium, left atrium, right ventricle, left ventricle. So if it is right-sided heart failure, so here is pulmonary veins. These are pulmonary veins, right? Okay, and here is the vena cava, superior vena cava or inferior vena cava. Okay, so if it is a left-sided heart failure, means the pathology lies in the left ventricle. What it will do? Left heart failure, there is a building of the pressure. So left ventricle unable to push out the blood. So blood is accumulating in the left ventricle and then into to the left atrium. So there is a back pressure, right? So ultimately there is an increased venous pressure in these pulmonary veins, right? So this increased pulmonary venous pressure will lead to increased hydrostatic pressure in the pulmonary capillaries, right? Nevin?
Yes.
Okay, why it is so important? Because USMLE love to ask arrows question. Love to ask arrows question. Let's suppose the left heart
Yes.
failure.
Mm.
Okay, so left heart failure, what are the causes of the left heart failure? It may be MI,
Myocardial infarction.
yes. It may be dilated cardiomyopathy, right? Okay, so left heart failure present with orthopnea. Why orthopnea and dyspnea? Because of
Pulmonary congestion.
pulmonary congestion, pulmonary edema, because of increased pulmonary venous pressure, right?
Yes.
So it will lead to the pulmonary edema. So left heart failure will lead to pulmonary edema. What about right-sided heart failure? Does it lead to the pulmonary edema?
No.
So
Systemic congestion.
if this is a right ventricular failure, so it will lead to the backward buildup of the backward pressure. So ultimately the pressure is built up in the superior vena cava and it will present with increased jugular venous distension.
Jugular venous pressure. Jugular venous pressure.
Yes, increased JVP, and this back pressure will increase venous pressure in the liver. It may lead to hepatomegaly, right?
Yes.
And it ultimately lead to the peripheral edema, right?
Yes.
So we discussed left-sided heart failure lead to pulmonary edema, while right-sided heart failure lead to peripheral edema, right? So
Yes.
the left heart failure may lead to the right heart failure, right? Left heart failure is the cause of right heart failure as well, right? So in exam, they ask about the arrows, like they give you the clinical scenario of the symptom of the heart failure, right? And they are asking about what will happen to hydrostatic pressure, right? What will
Yes.
happen to venous pressure?
Yes.
Okay. What will happen to
Priest.
contractility? Contractility. They give you the ejection fraction as well in clinical witness, right?
Yes.
Okay. If they give you the ejection fraction is, what is the normal ejection fraction?
50%.
Let's suppose the ejection fraction is 35%. And they has a typical sign and symptom of the clinical heart failure. What will happen to the hydrostatic pressure? Increase, decrease, remain unchanged.
Increased.
Increase. What will happen to the venous pressure?
Increased.
What will happen to the contractility?
Decreased.
Okay. Sometimes they give you the cardiac output as well. So many arrows to confuse you, right? Okay, sometimes they give you the ANP and BNP in heart failure. It will increase or decrease in heart failure.
Increase.
Increase.
It is
Okay. So you will
released from the
expect
atrium.
there are so many questions that are based on different arrows, right?
Yes.
So prepare these kind of things. Okay. The differences between systolic and diastolic heart failure. Okay. So what about the ejection fraction? What about the ejection fraction?
Decreased.
Ejection fraction is decreased. In what about in diastolic heart failure? Ejection fraction
Normal. Normal.
normal. Okay. What about the contractility in diastolic heart failure?
Decrease.
Increased or maintained.
Increase.
Maintained.
Maintain, yeah.
What about in systolic? Contractility is decreased
Decreased.
contractility.
Decrease.
Decrease.
So these kind of the arrows or differences are very important, right? Okay.
Yes.
What about the end diastolic volume?
Increased.
And diastolic volume is
Yes.
increased in
Yes,
systolic heart failure. And what about
Yes.
in diastolic heart failure?
Decreased.
As decrease.
Sorry,
Decreased.
It's either
normal.
maintain, yeah.
It's
Normal.
normal.
Okay.
Why it is a normal? Although
Because
it
the
should
heart
be
is already dilated. Yeah.
in diastolic heart failure. No.
No, hypertrophic.
So in diastolic heart failure, So there is concentric hypertrophy, right? Concentric hypertrophy takes place. Concentric hypertrophy means thickened or stiff,
In parallel.
thickened or ventricle, right?
Mm.
So
Yes.
it means that, and the chamber size may be decreased, right? Because of hypertrophy. Concentric, because of the concentric hypertrophy, not eccentric hypertrophy. Eccentric hypertrophy takes place in dilated cardiomyopathy. And dilated cardiomyopathy is a cause of systolic heart failure, right?
Yes. Yes.
Dilated
Yes.
cardiomyopathy is. So again, this is a very high yield concept. So in concentric hypertrophy, sarcomeres are added in
Parallel.
Concentric and
parallel.
they're parallel.
Parallel. While in eccentric, that takes place in dilated
Series.
cardiomyopathy in
It's
series,
it's series. Yeah.
right?
Yes.
Yeah.
And diastolic volume is increased. Normal in diastolic heart failure, not unchanged, because the end diastolic pressure is changed, is increased, right? And diastolic pressure is increased. If end diastolic pressure is increased, what will affect on compliance? Compliance will increase, decrease, remain unchanged.
Decrease.
Decrease.
Decrease. What is the formula of the compliance?
Volume over pressure.
Okay. So if the pressure is increased, compliance will decrease. If volume is increased, compliance will increase. So in this case, the pressure is increased, so compliance is decreased, right?
Can you go over that?
Sorry?
Concept? I was asking if you could go over that concept with that you just talked about.
Okay. If the end diastolic pressure is increased, right?
Yes.
It means that compliance is decreased. Why compliance is decreased? Because the formula of the compliance is delta V over delta P. So pressure is increased and compliance is inversely related to pressure and directly related to the volume, right? Pressure increase,
Yes.
compliance decrease, right?
Yes.
Okay. So the causes, what are the causes of the diastolic heart failure?
Hypertrophic cardiomyopathy.
Okay, hypertrophic cardiomyopathy. Hypertrophic
Systemic
systemic hypertension.
hypertension.
Okay. Yes. What about the causes of the systolic heart failure?
Dilated cardiomyopathy. Volume
Dilated?
overload. Congestive heart failure.
Yes.
Yeah.
Dilated cardiomyopathy?
Yeah, we could have it could be due to like some drugs like doxorubicin.
Yes.
Yes.
Yes. Microbiology component, Chagas disease, Coxsackie.
Exactly. Absolutely right. Okay.
Myocarditis.
Can anybody tell me any any heart failure in which cardiac output is increased. Can anybody tell me the name of that heart failure in which cardiac output is increased?
Diastolic heart failure.
Anaphylactic.
Yes, and a shock,
Hyperdynamic.
anaphylactic shock.
So it is high
Anemia.
output heart failure.
Hyperthyroidism, hypothyroid.
Hyperdynamic circulations.
Okay. So the arrow question. This is a basically the rare type of the heart failure. What will happen to the systemic vascular resistance in high output heart failure? What happened to the cardiac output? And what happened to the venous return? So this is high yield concept. High output failure. High output heart failure. What happened to the systemic vascular resistance? Increase, decrease, remain, and change.
Decrease.
Okay, decrease. What about cardiac output?
Increase.
Increased.
What about venous return?
Increase.
Increased.
Increase. Okay. Now I'm moving toward the causes. So causes of the high output heart failure. You're right. Hyperthyroidism,
AV malformation.
AV malformation,
Anemia.
severe anemia, not simple anemia.
Okay.
Severe anemia.
I have a small doubt. What is the difference between SVR and VR?
SVR is basically the systemic vascular resistance. It is you can say that the CPR. It's a resistance, peripheral resistance. And venous
Yes.
return is the amount of the blood that is
Okay. Understood. Okay. Thank you.
Does any vitamin deficiency lead to the high output?
Very, very.
Yes. Berry.
Which vitamin?
Thiamine.
Thiamine. Okay. What is the most common cause of the high output heart failure?
Obesity.
Yes. Morbid obesity. Most common cause is
Morbid obesity.
morbid obesity. Morbid obesity. Any orthopedic pathology? Any other that will lead to the high output heart failure?
You said if any what?
Any other musculoskeletal pathology that lead to high output heart failure?
Bahajat
Can you
disease.
give a
Paget disease.
yes.
Okay. So this is a today last concept about heart failure. So this is heart failure with reduced ejection fraction, and this is heart failure with preserved ejection fraction, right? So the reduced ejection fraction, this is the normal contractility, right? The contractility is going down, right?
Yes.
So the contractility is going down. And what about the end diastolic volume? It is increased. This is normal. This is normal. And this is in heart failure. So it will increase end diastolic volume. right? So sometimes they give you this kind of the pressure volume loops as well, right? And you have to identify which one. So this is the normal contractility. So this is heart failure with preserved ejection fraction. So the contractility is normal, right? Normal contractility. What about the compliance? So the compliance is decreased. Why? Because the pressure is increased. This is the normal pressure, this one, right? So, but in pathology, in heart failure, preserved heart failure with the preserved ejection fraction, this volume, or sorry, this and
Pressure
diastolic
increase.
pressure and diastolic pressure is increased, right? So this end diastolic pressure is increased. It will lead to the decreased compliance, right?
Can you go over that, please?
Okay. One time again. Okay. So this is normal and diastolic volume, right?
Yes.
And this is the normal and diastolic pressure as well, right? Normal
Yes.
and diastolic pressure. This is a heart failure condition with preserved ejection fraction. What about the end diastolic pressure? Increase or decrease?
Increase.
So end diastolic pressure is increase and diastolic pressure, right? So if
Yes.
the pressure is increased, what about the compliance?
But then the
Compliance will
compliance is
decrease.
This
decrease.
is so simple, right?
Yes.